Small ma'am? Okay. Banu?
Yeah.
We'll start on time illa Banu.
9 பேர் தான் இருக்காங்க சித்ரா. ஒரு 5 இப்ப இன்னும் டைம் ஆகல. 2 to 4 தானே. Another 5 minutes will wait.
Okay. Sure. Dear all, we'll just start another few minutes. So please bear with us. Hello, Dr. Sarun Kumar. Welcome.
Madam, good morning. Good evening.
Good afternoon, Sarun Kumar.
Good afternoon, madam. We also wanted to make this program from our society also. அதனால தான் எப்படி பண்றதுன்னு உங்ககிட்ட கேட்டுக்கிறேன். ப்ரோக்ராம் முடியட்டும்.
முடிஞ்சிச்சா உங்க ப்ரோக்ராம்?
இல்ல எங்க ப்ரோக்ராம் பண்ண முடியல. மேடம் வந்து இங்கேயும் பண்ண சொன்னாங்க. முடிச்சிட்டு வந்து நான் பேசுறேன்.
ஓகே ஃபைன் சரி. அப்ப உங்க மெம்பர்ஸ் என்ன ஜாயின் பண்ண சொல்ல வேண்டியதானே?
சொல்லிட்டேன்.
உங்க ஃபேஸ் ரொம்ப blur அடிக்குது. ரொம்ப லைட்
ஷீலா ஒரு 245 அந்த ரேஞ்சில் அந்த இது கொடுக்கு காஃபி. ஐ மீன் அந்த சுக்கு.
Banu? Banu?
Yes, hello. Yeah.
In 2 minutes
Ready.
we'll start, Banu.
Yeah.
2:05 will start. Okay.
Okay.
Just 1 minute introduction. அதுக்கப்புறம் நீங்க வந்து start பண்ணிக்கலாம். Okay.
Okay. You will give an introduction, right?
ஆமா பானு. Short. நீங்க கடைசில conclude பண்ணுங்க.
And you can tell about the course, I mean, pre-test, the way they registered.
They have to do the pre-test. அப்பதான்
register. They can pass on the thing to people.
அது automatically only if they do, they will get. Madam, good afternoon, ma'am.
Hi.
Good afternoon.
உங்க slide எல்லாம் check பண்ணிட்டீங்களா madam? You want your slides to be checked?
Yeah. Let me check.
Just check off, madam. அதுக்கப்புறம் we'll start the meeting. Dr. Shriman, just allow madam to share her slides. Dr. Shriman Kumar. Hello.
Yes, madam.
Please allow madam to share her slides.
I've allowed, madam.
Dr. Suma, madam.
Yes, ma'am. I did.
Yeah.
No, it's not yet.
No, you have put your PowerPoint on your thingla.
Yeah. Mail போட்டு
அண்ணா ஓபன் பண்ணி வெச்சிட்டீங்களா?
இல்ல, host disabled the participant screen sharing.
Suman, it is Dr. Suma. You please enable her now. Kumar? Hello?
Yes, madam. I'm doing, madam.
Yeah. See, only 3 people are going to talk. Me, Suma, madam, you make her the co-host. Make Dr. Suma co-host. Okay. Madam, now you made co-host, ma'am.
Okay. You can see then?
Yes, ma'am. Full screen. Full screen. And slide show போங்க மேடம், அங்க மேல இருக்கு. Okay. Yes, ma'am. Okay. Sorry, madam. Okay.
Thank you.
Okay, fine. Can we start, ma'am? Shriman Kumar, can we go?
Yes, ma'am.
Okay, fine. A very good afternoon and welcome to this meeting. Now, just a few words before we go on to the main session. Globally, roughly around 76 million abortions takes place every year. Of it, in India, there are roughly around 15.6 million abortions which are happening. This is in 2015. Now, if we see what really happens is 1/3 of the third most important cause of maternal mortality is because of abortions. That's very, very alarming, because after hemorrhage and PH, the next common cause for a person to die because of sepsis and abortions is really something very alarming. So now, globally, there are being steps to reduce this and to improve the maternal mortality, and also to bring about what is known as a respectable abortion care. Now, all of us know that the MTP Act has been amended in September 2021, and today's meeting is supposed to hear about all those MTP Acts, various types of abortion, and what exactly is respectful abortion care.
1 minute.
Now, only around 20% of all patients of abortion are done in certified centers. The rest of the cases are done either by patients themselves who buy the medications over the counter or by quacks. So in this program, along with WHO and Ministry of Health and Welfare, FOXI has decided to conduct this respectful abortion care. So in fact, a few months ago, I had put up in the Cox in the WhatsApp group that whoever wants to join us they called for teachers training of trainers. So whoever wanted could attend those courses and then become certified trainers. So in that way, Dr. Suma Natarajan and Dr. Bhanumati were the first persons to become TOT trainers for this RAC program. And now they are here as a faculty. In the next round, I think 3 or 4 more people got enrolled. So we will be conducting this meeting today on behalf of Foxy and RAC. So there are totally 4 modules. The first one will be about MTP. Second one is about abortions. Third one is about the saver modules. And lastly, about contraception. So I thank our president, Dr. Shantakumari, and the entire team of Respectful Abortion Care for having made this possible. And in fact, all Foxygens, all the 36,000 people who are Foxy members are supposed to take this training, and so that the way in which we do the abortions will be more standardized. And the idea is to bring about a standard of care, what drug to use, how to use, what is the follow-up, and what are we supposed to do, so that throughout the country we will be able to follow the same principles. In fact, before this, my thoughts also was different, and after this, what I have also done, I mean, I have really learned a lot about this, and then my thinking about abortions also has changed. So this has, I'm sure this would benefit everybody, all of us, and we should be able to put it into practice and see what best we can give our patient, because I realize that every woman has a right to have an abortion, because it's very common for us to say, why did you not use a contraception? Fine, you become pregnant, go ahead and continue the pregnancy. But after listening to all these talks, I realized that is not the way in which we have to go forwards. We have to respect her right, and then we should see that everything is being done in a very correct manner, so that she's able to, in a dignified manner, so that she will be able to go through the entire thing without any complication. That should be our aim. We should not cause any harm to us, or whatever is within our limits, we should be able to give her the benefit. With these few words, I request Dr. Bhanumati to take over and then talk about MTP. Over to you, Bhanumati. I'm sure all of you have done the pre-test. Listen carefully, you have to do the post-test, and only when you pass through this post-test, you'll be given a certificate. With the post-test will be done immediately. When you log out, you have to do it immediately. Sriman, you have to link this after when they log out for the post-test.
Yes, right. Okay, am I allowed to share?
Yeah, Bhanu, you can go. Sriman, please allow Dr. Bhanumati to do her slide sharing.
Madam is already hosted.
Yeah, I've done it. I'm doing it.
Yeah.
Is it okay? Yeah. Good afternoon to one and all here who have assembled for the real important aspect of the abortion, how to know about in a streamlined fashion, which has been designed by in alliance with the WHO by Foxy. It's a very good important step towards the health of women. As Dr. Chitra was telling, the safety part of it and the dignity part of it has been taken care. Already we have the respectful maternity care, now the respectful abortion care, which is going to be the safe and comprehensive care towards abortion. And actually this amendment of this MTP Act has come in 2021, and it is one of the very few countries which has got all the important amendments and very much safe for the person who is doing and as well as the person requesting for it. Today, let us see what is happening to what are the amendments and how to go about revised law for the MTP. Actually, next slide. What are the new laws and what are the changes in the rules? As I mentioned, it contributes 8% of the maternal deaths per year due to abortions, and it is one of the third leading cause of the maternal mortality. And nearly 2 out of the 3 of the abortions performed are deemed unsafe. That is why they are having the morbidity or mortality. Nearly half of the pregnancy-related deaths are in women and girls under 24 years. This is a very sad thing, because young women who are supposed to have a longer life are ending their coming to an end because of this unsafe practice or anything. The law has been implemented by British government way back in 1860, and abortion was considered as a very culpable homicide. So it was written like that. But after so many years, like 1967, then the British government has changed in their country that it has become a law. But only in 1971, the first MTP Act has come. So we accordingly we have got so many changes have come. And when is abortion considered safe? As for WHO and other things, by appropriate methods by trained persons. So even if one is not satisfied, one criteria not met, then it becomes less safe, and both are not met. You have to it becomes unsafe. They cause more problems. So it is a medical termination of pregnancy amendment 2021. It's a safe and comprehensive care which has brought out many aspects and feasible for everybody, is accessible to all women, so that it is practiced in a proper way, and people are getting benefits out of it. Let us look into the salient features of the MTP amendment in 2021. There are modifications in the requirement of the provider. The 1971 Act had given the requirement of opinion of one doctor, one provider for MTP up to 12 weeks, and for 12 to 20 weeks you require two doctors. But in the present amendment, requirement of opinion, only one registered medical practitioner up to 20 weeks of gestation. Beyond 20 and 24, you require 20. Two doctors are required to give an opinion and come to a consensus. Actually, this increases the number of facilities, especially in the public sector, like PHCs or people in the remote areas where you need to find out another person equally equipped to come to a decision and offer the procedure. This is regarding the provider. And modification for the vulnerable group of women. In the previous act, it was permissible beyond 20 weeks only when it is immediately necessary to save the life. Actually, to begin with, to save the woman's life, only the abortion was allowed. But now, on the 1971 Act subsequently has given up beyond 20 weeks only when it is immediately necessary to save the life of they consider the gestational age. Now it has been enhanced, the upper gestation limit from 20 to 24 weeks in special and vulnerable categories of women. Further enhancement of the birth defects not compatible with life on medical board consensus. So these in stepwise, you have to get permission and then go in a proper way. So this increases the access for vulnerable women to safe and legal abortion defined by the Rules Committee, includes violence victims and others. Having seen the gestational age and who is the provider, and regarding the birth defects, often we come across latest, around 22 weeks or 26 weeks, some new heart anomaly or some anomaly which is lethal has been detected, and the parents are panicking. This act had upper gestation limit does not apply in cases of pregnancies with a substantial fetal abnormalities, but it will be decided by the medical board. The thing is, you have to put up to the medical board explaining about the defect, then they'll give the permission and then you can go ahead with that. So the increases the access to the safe and legal abortion services beyond the legal limit for termination of pregnancies with substantial fetal anomalies diagnosed which are late, thus reducing unsafe abortions and court cases. And the fourth one will be a marital status. They look at the condition of failure of contraceptive was applicable for only married women or her husband. But presently, the condition of failure of contraceptive to be extended to a woman or her partner. It doesn't say anything beyond that. So it is open statement, open blanket statement. So irrespective of the marriage processing age, especially with the upcoming changes in the legal age of marriage, an important advancement for increasing access to for safe abortion. And they are very particular when they say respectful abortion care. They are really looking at the privacy and the dignity of the person who is undergoing the abortion. The previous act was mentioning the medical termination of pregnancy, which was regulated in 2003, that information should not be disclosed except under authority of law. But presently, name and other particulars of a woman who has been terminated shall not be revealed except to a person authorized by any law for the time being in force. So this is also a very good step. So they are looking into each and every aspect of the this procedure. So this increases the privacy and confidentiality of the abortion seekers, and but need to safeguard rights and dignity of the woman and provide respectful, bias-free services, including counseling and contraception. They definitely they stress upon the post-abortal contraception and adequate counseling so that the lady takes it in a proper sense. And it really prioritizes the confidentiality and safety, and name and other particulars of any woman seeking abortion to be confidential except a person authorized in any law for the time being enforced. All are practicing MTPs nowadays. You all know about the Form C and other things, the documentations which are kept, how to be maintaining that will be they are kept confidential. Even for the inspection authorities, they are not supposed to show that thing. The ground of failure of contraceptive has been extended to women and her partner. This involves the husband as well. So the husband or the partner, they are very, very clever in putting the words and using the. So it is very broad statement they have given. So the rules under MTP Amendment in 2021 defines three things. One is special or vulnerable category women eligible for extended gestational period for termination from 20 to 24 weeks, which is really important because all were around 22 weeks. Some things are some anomalies, some things come up, and so they need to undergo termination. And that the norms for the registered medical practice has been clearly sketched out so that there is no confusion on that. The powers and functions of the medical boards, how it has to work, how it can give the decision regarding the termination when it is detected late and beyond 24 weeks. And this is a special category of women eligible for MTP between 20 and 24 weeks. This has been elaborately mentioned. Number one will be the survivors of the sexual assault, rape, or incest. And women with pregnancy in humanitarian settings like a disaster or emergency situation declared by the government, which is very apt because that time, in addition to the general emergency, this also puts them under pressure. So we as a healthcare provider will be helpful to them, and we will not allow them to go. I think in COVID situations also, this was, going on with the telephonic or whatever, telemedicine, it was going on. And change of marital status during the ongoing pregnancy, like widowhood and divorce. This doesn't matter. Actually, some people will be seeking for a medical abortion when it is in the court. The case is in the court. Sometimes we will be worried whether to take it up or not because the court we have to go according to the law. So these things are also explained like that. And women with physical disabilities, major disability as per criteria under the Disability Act. Actually, it also allows us to read something more about the laws. So when I go through that criteria under the Disability Act, there are some 21 diseases have been included, major visual impairment, hearing impairment, speech and mental retardation, even hemophilia, sickle cell anemia, thalassemia, muscular dystrophy, all those things are actually, it's nice to see it's more and more knowledge regarding the legal aspect of it, so that when even the leprosy people who have recovered from that, all those things are included in that. So you can give them the right to undergo abortion when they seek for it. And mentally ill women, including mental retardation, minors, there is definitely a role to, but as mentioned, some paper has given some little different statement regarding the minors to take a consent whether to report to the police or not. But it has been mentioned very clearly under the POCSO Act 2012 section. It has to be reported to the police and it has to be done. I think that is a better understanding when we deal with the thing, and the consent and the examination are all clearly given so that we have to treat them properly, but the police intimation is a mandatory. And the fetal malformations incompatible with the child born, it will suffer from such physical or mental abnormalities to be seriously handicapped. So those things are also taken. So this 7 groups really covering the entire spectrum of women who are seeking for abortions. And the norms for the RMP, when they hold a MBBS degree or a postgraduate degree, both can take up. And what is the limitation? A medical practitioner assisted 25 cases, or he has done 5 cases independently, or he has done 6 months house surgery in the obstetrics and gynec department, or whether when they hold a postgraduate degree, automatically they get qualified to do the thing. And medical practitioner who has experience for at least 1 year in the practice of obstetrics, they are all eligible to do the. So the norms have been determined. Up to 20 weeks of gestation, only one RMP is required, opinion is required. After that, 20 to 24 weeks, 2 people have to give the opinion. Beyond 24 weeks, we have to submit an application. It will be decided by the medical board. And when you look at under the amended rules, an additional category of the provider has been added, but that is depending upon the gestational age. Up to 9 weeks with the medical records, the RMP with the experience in the practice of obstetrics and gynecology at any hospital for 3 months, or training with performance of 10 cases of MTP by MMA under supervision of RMP in a hospital or a training institute approved for this purpose by the government. So more and more people will be trained and asked to practice abortion in a safer way. So, this has been in a different format till 9
Banu,
weeks. Yes.
sorry to interrupt. Kumar,
No,
there's
ma'am.
too much of noise. Can you just mute everybody except the speaker? Mute everybody. There's too much of noise. Only the person who's talking, please keep them unmuted. Okay, Banu.
Thank you. So they have divided the gestational age up to 9 weeks and beyond 9 to 12 weeks, and then 12 to 20 and 20 to 24 weeks. So till 9 weeks, RMP, all these people with MBBS degree or the postgraduate or degree through and through, they can do everything. But with the MBBS degree, they have certain experiences. This is mentioned, like already we have told about that. 6 months of house surgery or 1 year in the obstetrics and gynae department, or assisted 25 cases, and otherwise undergone training within an institution where they are giving under the supervision of the registered medical practitioner, and only one person is opinion is required. So this is till 9 weeks, and till 12 weeks you really cut down certain things. You can have as 25 cases. The first category has gone out. Now only 25 cases of MTP they have assisted, at least 5 independently. And if you are holding postgraduate degree, automatically you are eligible. And 6 months or 1 year in practice in the Department of Obstetrics also sufficient to take care of the pregnancy till 12 weeks. And only one doctor's opinion is required. Beyond 12 weeks until 20 weeks, again, little more, you have to have a 1 year or 6 months training has to be there, or a postgraduate degree. That MBBS with the 25 cases has not been taken, but still one person's opinion is required. So when you really, somebody is undergoing taking care of this gestational age and the experience of the practitioner, please fulfill all these criteria before you take up. Beyond 20 weeks till 24 weeks, experience and training requirement for RMPs who definitely a postgraduate degree or diploma holder, and 6 months of house surgeons and 1 year of 6 months or 1 year, but they have to give a 2 doctors opinion. This is a final beyond the 20 to 24 weeks. And beyond 24 weeks, only the person with the postgraduate diploma and 1 year experience in the Department of OG will be eligible to do that. And in addition, definitely opinion of the medical board is required for the termination of procedure. When advised by the medical board, it's carried out with safety precautions along with the appropriate counseling and at an approved place. Usually they have to give an application stating the reason or the anomaly which is there, that has been. What is a medical board? What is the composition of the medical board? Usually it's a gynecologist, pediatrician and a radiologist. And actually, in our setup, Tamil Nadu, it's almost everybody is in the government services. The Dr. Gauri, the director of the DHS, she is the head for our area. And the doctors from the government medical colleges, the gynecologists, pediatrician, radiologists, all from those areas form the medical board. And it will be submitted, the application has to be submitted in the Form D. Then that will be with explaining, Form D means it's a letter. You have to do the, they submit the details. What is the power of the medical boards? To allow or deny termination of pregnancy beyond 24 weeks of gestation period, only after due consideration and ensuring that the procedure would be safe for the woman at that gestation age, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. This is a very crucial, and it has been taken in a nice way by the government of India to make this amendment. Otherwise, there will be a lot of cases going on to get the permission, and then time has been elapsing, and again the gestation age goes up. So the risk of abortion and the subsequent problems will be there. So these are little taken care so that the safe abortion practice can be there. And it has co-opt other specialists in the board and ask for any additional investigation if required for deciding on the termination of pregnancy. So FOXI with the ministry guidance and WHO support as part of RUC can operate and host medical board information on website. Actually, this will be in process. We will be getting to know the further information regarding that. Actually, I have requested Dr. Manon Mani from Government Medical College to highlight on the certain regarding the medical board, because we need to know to whom we have to apply, and whatever said and done, they say that you apply, and I mean to the medical board, if you apply, the decision will be taken within 3-4 days, and you can get the permission and do the procedure. Functions of the medical boards: to examine the woman and her reports, who would approach for the medical termination of pregnancy, provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical. So they've given the time limit so that the advancing of the gestational age will not take place. To ensure that termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for medical termination. So even for the judgment, the opinion there, from the medical board, the time frame has been given as 3 days. Once you get the permission, you cannot just like that prolong for some reasons, whether they can, their party is ready, or whether they have some economic problems also. It has to be carried out within 5 days, so that no other maximum of 1 week, 8 days is there. So they have to finish the procedure. So remember, FOXI has an important role to play in ensuring there are functional medical board in every state. That's what we mentioned. It is the formed by the government doctors who are in the particular departments. So all of you would have been done the pre-test and post-test, and once you do that, you will be getting all that. To summarize, what is the really the changes in the amendment? It is regarding opinion of the provider, gestational age limit in the vulnerable group, and gestational age limit in case of substantial fetal anomalies or condition of the failure of contraception. We know that up to 20 weeks, only one doctor opinion is required, and beyond 20 to 24 weeks, 2 doctors' opinion is required. And the upper limit of the termination has been from the from 20 to 24 weeks for sexual assault survivors, victims of incest, and other vulnerable women. When there is anomaly is detected very late, that can be decided by the medical board, and you can get the proper thing. So, but these are the real welcoming changes in the MTP Act, which will enable everybody. And subsequently, the safety and confidentiality, everything is also taken care. When we really look into the details of that, we are happy that this practice will definitely save the people from the mishaps happening in around abortion. Thank you for opportunity. It's a wonderful program, so that streamlining of the abortion practices will be done by all of us, and all women will be in a good state of health. Thank you. I'll stop sharing. Chitra? Dr. Chitra? Any clarification or anything? Dr. Chitra, are you there?
Banu, there are no questions as of now. They are unmuting me. I did not know. There are no questions as of now. So once questions come, we'll take up.
Yeah. You can.
Okay.
Go ahead, please.
Okay. Thank you, Banu. Can you shall I share screen? Will you stop?
Yeah.
Okay. Okay.
Sure.
Yeah. Okay, fine. Thank you. Module 2. Banu, you stop sharing, Banu. Banu? Banu? Banu?
I have already done.
You stop sharing.
Already.
Banu. Banu Matinda Teridu. You stop sharing. You exit from that, Banu.
Okay. 1 minute. Yeah.
You exit from that. Stop sharing. Exit Panaga. Because now shared Panaka Adam Vardu. Banu Matinda.
1 minute.
Okay.
Share.
Kumar, can you help?
Yeah. Actually, I was earlier sharing. I did stop sharing actually. Once more I will
start sharing.
I did stop sharing now.
Okay. Okay, but let me see. Model respectful about okay.
It's not mine.
Okay, fine. Oh God. Under 1 minute. Kavi, go to Shawani. அந்த abortion நீங்க வெச்சீங்க காணுமே நான் இங்க வெச்சதுக்கு காணுமே அந்த abortion டவுன்லோட் பண்ணி சொல்லுங்க நீங்க
Chitra, which module or different one? Which module you want?
But I want okay, one I've reached safe abortions. Okay, yeah, Banu, correct one this Banu. Okay. Is it seen?
Yeah.
Okay. Now thank you. Slideshow the full screen போட்டுருக்கேன்.
இல்ல சரி போடுங்க ஸ்லைட் ஷோ
full screen தான் பண்ணோம் வரலையா
ஸ்லைட் ஷோ வரல இரு பார்க்கலாம் வரல ஸ்லைட் ஷோ கீழ போடுங்க
ஸ்லைட் ஷோ
வரலையா ஓகே என்னப்பா
அது கீழ போட்டா வந்துருமே கீழ போடுங்க அதேதான் put it as slide இது slide better it's come
பார்க்க மல்லுது Okay, a very good afternoon. So what I'm going to tell you all is what is the existing guidelines, pre-abortion assessment, how exactly will we go about doing the abortion, and what are the other methods, is it surgical, medical methods of abortion. So now the WHO is brought about various guidelines. Right from 2012 onwards, we've been having many guidelines about safe abortion, but the breakthrough came in 2018 when medical abortions started coming into the picture. And now all of us, hardly anybody does these surgical abortions. Most of us only resort to medical abortions. So this is a roadmap on safe abortions by the WHO. 2012, we had technical and policy guidelines for health systems. 2014, we had the clinical practice handbook for safe abortions. 2015, the healthcare role in providing safe abortions, because they knew that many of these patients seeking abortions were going to quacks, etc. So they enabled healthcare workers to do these abortions. And that was what was started in 2015. 2018 was the most important part, which is the medical methods for abortion, MMA, medical management of abortions. And 2019 is a consolidated guideline on self-care intervention for health. All these books are very, very small, maybe around 100 pages. So those who are interested can go through these books. Now, the historic change was in 2021, when just now you listened to Dr. Bhanumati saying that a lot of amendments in the new MTP Act. So, like she said, you all know all the main things on which this amendment has come to, and we have to know what are the changes as far as gestation age is concerned, what are how many practitioners are required to certify an abortion, and etc. Few things which are very, very important in our day-to-day practices. Now, for all abortion, there are three main areas which are important. One is what is the pre-abortion care? What exactly is the abortion, the procedure per se, and subsequently, what is the follow-up after an abortion? So let us take up one by one. So what is a pre-abortion care? How will you assess a person and how will you counsel the person? A detailed history is very, very important. You must find out how many days she's missed her periods, what was the flow like, was it normal or was it only spotting? Because sometimes she might come with a LMP and she might have missed and said only spotting a few days, she might take that as an LMP. So it's very important that you take a very, very detailed menstrual history. And apart from menstrual history, any other medical conditions or surgical interventions that she's had must also be taken into considerations. Any conditions like diabetes, a routine checkup that we do for all patients, so proper history is very, very important. Then general examination and a pelvic examination. Now, and lastly, lab investigations and what is the decision. So every patient, we have to tell them, initially examine her fully, get a history, examine her fully, do basic investigations. We will come to it in a while. We will touch about all these factors. And lastly, it's important that we tell the patients what are all the methods available. And then she has to make an informed consent as what she wants. Okay. Now, as far as LMP in gestation age is concerned, very often we have to accept that patients may not recall their LMP at all. So it's important for us to go both by LMP and by physical examination. When you do if the uterus is felt at the umbilicus, at the pubic symphysis, you will say it is 12 weeks. But below that, roughly, the size of the uterus will correspond to the period of gestation age. And beyond 12 weeks, you will be able to have a palpable uterus. And when you're having a disparity between your LMP and your findings, maybe you have to go in for further other investigations to confirm what exactly is the period of gestation. Now, this is an important thing. The guidelines say there is no need to do routine investigations. Now, all of us do basic investigation like hemoglobin, serology, etc. But what is the recommendation? If you want, you could do those things. Pregnancy test only if you have a doubt, is she pregnant or not. Hemoglobin must be done and an RH type, because especially if the person is RH negative, maybe you can do a hemoglobin and blood grouping. HIV, you can do a counseling, but again, all that is also only if you want to. It is not a compulsion. And when you do a vaginal examination, you find there's a lot of discharge, you could screen for sexually transmitted diseases. depending upon the person's conditions, if she's having a renal failure or a diabetes, etc., then maybe you could do the necessary investigations. So all these are not mandatory. It's only if you want to, you can do. So that means a person is requesting an abortion can just have the abortion without doing any of these investigations. We think she's totally fit. And the other most important thing is ultrasound also is not necessary to make a diagnosis of pregnancy. You are expected to do a diagnosis of pregnancy by clinical examination and by the history. But only if you suspect an ectopic or a missed abortion, then maybe you could do an ultrasound. There are, various whether to do an ultrasound is important or not, because sometimes we see patients who have been given an MT-people very early in pregnancy and then they come with an ectopic pregnancy. So you should use a discretion whether to do an ultrasound or not. But as for the guidelines, Indian guidelines, you don't require an ultrasound before proceeding to a medical termination of pregnancy. Now, this counseling is very, very important, because only based on this counseling, pre-abortion counseling, you will be able to either convince the patient or you could ask her to continue the pregnancy, whatever she wants. You give her the entire background and then she can decide what she wants to do. So you must find out why she wants a pregnancy to be terminated. What exactly is the reason and what is the risk? Because sometimes we see patients who would have been forced to have the abortion by her husband or in-laws or whatever. And then after that, they come with a lot of guilt in their minds. Why did I have this? So you must try to find out what exactly was the reason for her coming forward for this abortion. But at the same time, you must tell her this abortion is very safe, because you're going to do it in a place and by person who's qualified to do the abortion. So this importance is very, very important. I mean, this important factor should be told to her, that she need not worry. She's come to a center which has all the facilities and you could make it very safe for. So it's important to impart that knowledge to the patient. She's come requesting for an abortion, but it is our duty to enforce and tell her that she's in safe hands, that everything would be done properly for her. You must list out all the available methods for abortions. You must display all the basket of techniques that you have, and then she can choose from it. But for every method, you have to tell her what exactly is the complications, what are the risk factors, what are the complications with each method. Has to be told to the patient very carefully. And after the abortion, it's also very important, because at that time they're very receptive. So you must tell her that if you do not use any contraception, the same thing is going to likely to happen again. And at that time, you must sort of prime her for contraception later, because that is a time when there are many things that you can administer contraceptive at the same sitting. So it's important that you prime the patient during the pre-abortion counseling itself. And you must also tell her that she can get back to her activities. There is no need to take any rest for 1 week or 10 days. No need at all. She can go back and carry on her old routine activities and follow up if necessary. We shall see when all a person has to come for the follow-up. Now, it's very important that you document it. Informed consent should be obtained for the patient, just like how you have any other abortion. You must get her informed consent. So, what is a clinical care of abortion? Now, until 9 weeks, you only do a medical termination of pregnancy. So, up to 9 weeks. So, on this side, you are able to see the chart. Up to 7 weeks, that is up to 49 days, you give her only misoprostol, wait for 24 to 48 hours, and then subsequently you give her a single dose of misoprostol. 800 micrograms can be given either sublingually, buccally, vaginally, or orally. It can be given in 4 ways. Similarly, up to 9 weeks, you don't normally advise medical termination after the 9th week of pregnancy. So up to 9 weeks, the same thing. Mifepristone 200 to prime the uterus, and then subsequently after 48 hours, you give her misoprostol. Now, globally, what is the recommendation? So, abortion, you could either have a first trimester abortion, you could have a second trimester abortion. There are different categories. In that book on abortions, this very beautifully given up to 12 weeks. What would you do if it's a missed abortion? What would you do if it's an incomplete abortion? What would you do if it's after if it's a second trimester? What are the method? What is the doses? So, because it's important for us to know what is the dose, what is the interval between the two drugs, and what is the maximum dose or minimum dose? What is the recommendation by the government and what is the recommendation by WHO? We have to know all these things. So less than 12 weeks, the global recommendation is you could use you could use mifepristone and misoprostol. It's a combination regime that you normally that is advised. You can also use misoprostol, or you could go for vacuum aspiration. These are the recommendations for the first trimester. In the 12th week, after the 12 weeks, once you come to the second trimester, the same thing, you could do mifepristone and misoprostol, or misoprostol alone, or you do a dilatation and evacuation. And you don't say a DNC because a sharp period should not be used when you do a abortion. So what are the methods of first trimester abortion? So far what we've seen is what are all the pre-abortion counseling. And then we move on to the crux of the matter. What is the methods of first trimester abortion? Can you please unmute everybody? Kumar, please unmute everybody, Kumar. Okay. So what are the methods of first trimester abortion? All of us know medical methods and second is surgical methods. Till very recently, maybe a few years ago, we were only many of us were only using surgical methods. But after seeing medical methods of abortion so effective, at least abortion is complete in more than 85% of patients. So many of us only resort to abortion, but still in some places they still do surgical abortions. So let us take up one by one. So this combination method, what is this mifepristone doing? So mifepristone is actually an anti-progesterone, and all of us know that progesterones are important for continuation of pregnancy. So once an anti-progesterone is given, it sort of the effects of progesterones come down, and you prime the uterus. And subsequently, when you give another drug like mifepristone, when you give a drug like PGE1 analog, which is a misoprostol, that will act upon the primed uterus and help in expulsion of the products of conception. We bring about uterine contractions and help in expulsion of the process. So a combination of this priming initially followed by giving the prostaglandin E1 is found to be better. Now, what are the advantages of this tablet misoprostol? This tablet misoprostol, the advantage is that it can be kept at room temperature. It is very cheap, and there are not much of side effects, and can be given by many different routes, whichever the patient finds it comfortable. So it's a great advantage of misoprostol, and it's very effective also. That's another very important. Effective. It can be stored, not costly, less side effects. Okay. So let us see the regime on day 1. And there are changes between this regime and what was done earlier. I will tell you shortly. On day 1, it is you give mifepristone. Mifepristone, the dose that you give is only 200 milligrams is given orally. And note, if the person is Rh negative, you have to administer anti-D on the same time. We normally give anti-D after the product is expulsion, but here they say you start giving anti-D on the same day as the day 1 of mifepristone. That is something which all of us have to remember. On day 3, you give, after this mifepristone is given, you give a misoprostol. So what is the dose of misoprostol? 400 microgram misoprostol up to 7 weeks. Okay, so you divide the 7 weeks and more than 7 weeks. So up to 7 weeks, you only give her 2 tablets of 200 micrograms each tablet. So totally only 400 micrograms of misoprostol is given. Now it could be given, like I said, in all these different routes. And if it's beyond 7 weeks, you give her a single tablet of 800 micrograms. So less than 7 weeks, only 400. 7 to so lesser the gestation age, you require a lesser dose, 400. If it's between 7 to 9, you give her 800. Now, in addition to that, it is important because these patients will have a lot of pain. You have to give her some analgesics, and anxiolytics may be given. She might have a lot of vomiting, so it's important. If she has vomiting, we also give her antiemetics. Contraception, we'll be talking about it later. So after this, so the first day you've given her mifepristone, day 3 you've given her, depending upon the gestation age, you've either given her 400 micrograms of misoprostol or 800 micrograms of misoprostol, and subsequently on day 15 you ask her to come for a follow-up just to see that everything is complete. Now let us see the different routes in which this misoprostol can be given. Orally, we can ask her to swallow all the tablets. But the side effects are patients can have a lot of diarrhea, vomiting, fever, and chills. What about buccal? So in buccal, what is buccal? What is sublingual? Buccal is when you place the tablets between the gums and the cheek, and then you swallow it after 30 minutes. So it's kept here between the gums and the cheek. That is said to be buccal. Now, in fact, they say buccal again has more fever and chills than with the vaginal route. Sublingual is said to be the best because sublingual is under the tongue. You keep it under the tongue and then you swallow the tablet after 30 minutes. Here again, you have one problem of giving prostaglandin, whether it is E1 or E2. Patients or many of them will have vomiting, diarrhea, fever. So you do not know what is the reason for the fever. So it's anticipated when you give them, they can have fever, chills, diarrhea, vomiting, etc. It's the same like how it is in vaginal route. But however, the plus point of sublingual is it has a very fast action, fast onset of action. And the highest rates are, highest concentration is with sublingual. So it's said to be, better. In a very short time, you could have peak levels which is achieved faster and maybe it will act better. Now, vaginally, the place in the vaginal fornix is it's not enough if we just keep it in the vagina. You must see that these tablets are kept in the deep fornix. So that is why you have to keep it, and she's instructed to ladder for 30 minutes. We normally just keep the 2 tablets or whatever in the vagina. You should keep it in the fornices. Go up to the fornices and keep it there. So here again, sometimes these tablets may not be absorbed. So these are different routes. Again, there's a diagram showing the buccal and the sublingual route. So if it's 12 weeks, so remember, if it's 7 weeks, you only give her 400. 7 to 9 weeks, 800. Then again, up to any patient with less than 12 weeks, you give them, it's a combined dose. You can either use a combined dose, there are 3 regimens, a combined dose, only misoprostol alone, or you can give suction evacuation. So if it is less than 12 weeks, you give a mifepristone initially on day 1, and then on day 3, you give her 800 micrograms of misoprostol either buccally, vaginally, or sublingually. If it's misoprostol alone, then you forget about this mifepristone and only give her misoprostol. So these medical management of abortion services should be available everywhere because these drugs are very inexpensive and don't have to have to keep them under the refrigerator. So they could be available in the PHCs. In fact, they say even those ASHA workers can take these drugs and then give it to the people at home. So that is the advantage of MMA services. So additional services need to be provided to individuals seeking medical abortion. And that's the time when you can counsel them for STIs and HIV infection. And you could also support them for whatever, give them a lot of psychological support. And if necessary, you could, if you have identified some medical disorder that she has, they could send her or refer her to a higher center. Now, follow-up care. So we've done the abortion, we've given her the prescription. How do you follow up these patients? In fact, the follow-up need to be done only on day 15. So what is a follow-up? They say if you've done a combined method, given her mifepristone and then given her misoprostol, they say you don't have to do a subsequent follow-up at all. So routine follow-up is not necessary if it's following an uncomplicated medical abortion using both these drugs, a combined regime. We don't have to follow them. But however, if you've given her only misoprostol, when you're not adding mifepristone, only given her misoprostol, it is important that you follow up these patients and see whether the abortion is complete. So a single drug regime, you call them back on day 15. If it's a double drug regime, there is no need to follow. There's no need to call them back. But however, you may offer a checkup around 7 to 14 days to tell her about contraceptives and to give her some emotional support, or if you found out something to address any other complications that she's had. But as a rule, if she's expelled the products, there is no need to ask her to come back. Now, when she comes for follow-up, so you would have given these tablets and then asked her when she comes back, you must ask her, because she might tell you there's either bleeding or no bleeding. So you must find out whether she expelled any products, did she have any bleeding. In fact, after giving the 800 micrograms, within 4 to 6 hours, they will have the bleeding and expel the products of conception. So when she comes back, and the bleeding can continue for a few days, it can go up to 14 days, but bleeding beyond 45 days is said to be abnormal. Bleeding will not be prolonged for such a long time. So when she comes back, you must ask her, because some of them, a few small percentage of them can continue the pregnancy, or it could be an incomplete abortion. So in which case you must ask her, does she continue to have any symptoms of pregnancy? She continue to have vomiting, etc. Then you must really pay a little bit of attention to that. And you must ask her when she had the abortion, did she have any pain or any bleeding, how much of bleeding, all those things you must ask her. So MMA, what is the summary for medical management of abortion? On day 1, you after having done physical pelvic examination, you confirm whether she is 7 weeks or 9 weeks or more. On day 1, you give her mifepristone, and the same day you give her anti-D, which is Rh negative. You ask the woman to come back after 2 days, or you can give her the tablets. And you ask her to take the tablets. 800, if it's 7 weeks, give her 400. If it is more than 7 weeks, you give her 800 micrograms. Now, it's important also to tell them that after taking mifepristone alone, a small percentage of them might expel these products. So but you must remember that even if they've expelled the products, the schedule should be completed. You should give her the misoprostol schedule should be given. Now on day 3, when she comes back, you give her misoprostol should be given in whichever route you find is convenient, or whichever route the patient wants to have. You observe for 4 hours, and then at the same time you must give her some analgesics. The mean period of bleeding is up to 2 weeks, and these are the side effects which the patients can have: nausea, vomiting, diarrhea, etc. They should report to the center whenever there is excessive bleeding or pain, abdomen, or fever. And even after 24 hours after giving the misoprostol, suppose she's not had any bleeding, she's not expelled any products, she must come and report immediately. Okay. Now, you must do a pelvic exam. When she comes on day 15, there's a follow-up visit after 2 weeks. When she comes, you do a vaginal examination to find out whether the uterus has come back to its normal size, whether you think there are any products which are felt, it could be an incomplete abortion. You might be able to feel the products of conception within the uterine cavity. So you do a vaginal examination to confirm whether the abortion is complete. And then that is the time when you advise her regarding contraception. There's a separate talk on that, so I'm not going to touch into it. And then you must tell her the importance of using these contraceptives, and tell her that there is a risk that she could get pregnant immediately. Again, ultrasound pre and post also is not necessary. You must only do an ultrasound only if you think that the abortion is not complete. So what are all the side effects? One is pain. So the pain is very important. So you must support the person, give us a lot of psychological, because after an abortion, we do not know what were the circumstances, so she might be very upset. So it's important that you counsel the patient. Do not verbally abuse her. You must give her a lot of support. And basically, we should not look down upon all these patients. Oh, she's only come for abortion. So there might be some big history behind her, why she's seeking that. So it's important to be very sympathetic and show some empathy to all these patients. You must counsel them properly. And you have to give her good relief. You must give her some analgesics. In fact, the routine drug which is given is ibuprofen 400 milligrams can be given. And if she has a lot of vomiting, you may have to give her antiemetics. And if you think there is infection, you can give her antibiotics, otherwise not as a routine. Again, diarrhea is again self-limiting. There is no need to give her any drug for that. So supposing the person, like I said, only 85% of them might abort, but some of them might have an incomplete abortion, or sometimes it may not succeed at all. There could be a failure of MMA, in which case, what are we going to do? There are 2 options. You could either repeat the same MMA again, the same procedure that you did, you could repeat it again, or you could offer her a vacuum aspiration, whichever the patient wants, you could offer it. Suppose if you think it's incomplete, then what are you going to do? Again, if you think it's incomplete, you could offer her a suction evacuation. If it is, you could just repeat, a part of it is come down, then you could just repeat only misoprostol. Instead of giving her the entire 2 doses, you could just give her misoprostol, which is what many people do. Or you could just observe, because after a few days, it might automatically get expelled, so you could just observe. Unless the bleeding is very profuse. If the bleeding is very profuse, then what are we going to do? So there are 3 options. If it's incomplete, then you do a suction evacuation. You can only give her misoprostol, or you just observe. If nothing is expelled out, then you can either repeat the dose or you straight away go for a suction evacuation. Now, if it's incomplete and the bleeding is very excessive, then what are we supposed to do? So when will you say it is excessive bleeding? When every 2 hours she's soaking 2 pads fully, then you say it is excessive bleeding, in which case patients have to be kept under observation. We keep her for an hour or so, see how much the bleeding is, and then if the bleeding is okay, her vitals are normal, maybe you could send her back home. Meanwhile, you do a vaginal examination and see whether there are any products of conception which is felt in the cervical canal. You would think the products of conception are present, then you do a digital evacuation. And then once the patient is stable, you could send her back home. On the other hand, if even after removing whatever products were there, if you still think the bleeding is there, then you do an ultrasound. Ultrasound, you could have 3 options. You could have the entire pregnancy can continue, or you could only have bits which is present. Very often we see retained bits is there in the uterine cavity, or you could have very minimal bits. So if they're very minimal bits, you just wait and watch. If it's continuing, then you can do a vacuum aspiration. If the products are there, then you could either go back to only misoprostol alone, or you could do a vacuum aspiration. So basically, the patient is now she's bleeding profusely. Then if you do a vaginal examination, and then if there are products of conception, you remove the products of conception digitally. If the bleeding continues, you do an ultrasound. If there's very minimal products, you can just wait and watch. If the products are significant, then maybe you could either give a misoprostol again, or you straight away go for a suction evacuation. If the entire product is still there, then you straight away go for a vacuum aspiration. Now, this MMA also should be reported just like an MTP that we do. You have to fill up all the forms, like Form C, Form 1, Form 2, Form 3, all the forms, just like a vacuum aspiration that we do, everything has to be filled up. That is very, very important. So this is as far as medical management of abortion, MMA, is concerned. Next, we'll move on to MBA, or your suction evacuation. Now, earlier on, I'm sure all of us have done this vacuum aspiration up to 12 weeks of pregnancy. That is the mainstay. But WHO also says it's a safe method. But however, you should not do a sharp curettage. Now, I'm sure all of us have seen these MBA syringes. So you have to use these MBA syringes up to 12 weeks. You could use it. The size will depend upon what is the gestation age of the patient. Suppose the size of the cannula, if it's 8 weeks, then you use an 8 mm cannula. If it's 10 weeks, you use a 10 mm cannula. This is the electric pump that we use for suction evacuation, electric suction evacuation. Now, if it's a pregnancy, it's better to prime the cervix. So this priming of the cervix can be done with all these are different methods. You could give her oral mifepristone earlier, or you could give her misoprostol just 2 to 3 hours before the surgery. Maybe 400 micrograms can be given prior to surgery, because by the time you start the evacuation, products are already expelled and it will be very easy to complete the procedure. Or you could also use a lamiaria tent intracervically 6 to 24 hours prior to the procedure. Now, again, pain is very important. You must reduce the pain by giving her either pharmacological methods or non-pharmacological methods. Non-pharmacological methods is the most important, because she's so upset. You have to give her a lot of psychological support, and you must explain to the patient what exactly is going to happen and what are we expecting out of her, and tell her to be, you should be extremely gentle and very soft towards her. These are the drugs. You give her diazepam can be given if necessary, not as a routine. And for cervical dilatation, when you want to dilate the cervix, when you do this MBA, you could either use an intracervical injection with lignocaine, or you could just use NSAIDs. If she has a lot of cramping pain, you have to give her a ibuprofen. Now, MBA, these are the steps. So basically, I'm sure all of us would have seen these MBA syringes. You close the buttons, valve buttons, and then you have to create negative pressure. Once you create a negative pressure, keep it aside, and you must see that the person's bladder is empty. You clean, and then under aseptic precautions, you give a paracervical block. Then you have already chosen the size of the cannula that you want, the Cartman's cannula. Now introduce the cannula into the uterine cavity, which is being done here. Insert the cannula. Now after the cannula is inserted, then only you will attach the vacuum created pump. You attach it to the cannula and you slowly withdraw the cannula from the fundus and you rotate the cannula with gentle movements, move it up and down, keep on rotating it. And then ultimately after you rotate it, just release the button and then the products will come into the cannula. You can confirm whether the products are removed by emptying it into a bowl and then you can see the tissues there. And then if you see the plasma tissue, that will tell you whether it's a plasma that you removed. Okay. Now, and this is the way that you clean it after that. So to say that the uterine cavity is empty, you will be able to see only pink foam which is coming out. You will feel a gripping sensation. The uterus, the cannula will become very tight. You will not be able to move it as freely as we do so earlier on. That will tell you, and the bleeding also might stop. That will tell you that bleeding is mostly complete. That the abortion is mostly complete. Okay. So post procedure, like I said, you just observe the patient for some time, and then if she's fine, you could send her home. There's no need to keep her any further, and then see that that she has all the necessary information and medications, especially any drugs like painkillers, if necessary, can be given. And documentation is very important. You must fill up all the forms. All these patients will have an MMA card. So to fill up all the forms, tell her when the drug was given. You must document everything in that card, and you must ask her to come back for the follow-up. So aftercare is again, unless it is you use only one drug, it is not necessary to ask her to come for a follow-up. But if you can offer her a follow-up between 7 to 14 days, or you must tell her if she has excessive bleeding, that is very, very important. If it's excessive bleeding, she has to come to us immediately. Okay. In summary, basically, there is not much of technological changes which has happened. The dosing is slightly different, which has happened. Now, between this dosing and what was given earlier on was, initially they were giving a loading dose, and then they gave, say maybe 600 was the loading dose, and then you had given 400, 400, 400. That is not there in this recommendation. You, for less than 7 weeks, you give 400. More than 7 weeks, you straight away give her 800. And if necessary, you can repeat the dose in 400. So it's not necessary that you should repeat. Whereas earlier on, it was a loading dose, followed by loading dose, you had to give 400, 400. So that is the difference between this MMA, which was there earlier, and the latest guidelines. Okay. So not much has changed in technology. So it's very important as practitioners, providers, to ensure safety and quality, especially in the context of this amended law. Along with safety, the most important part is respectful abortion care, which I will tell you in a short while what exactly is this respectful abortion care. Okay. Okay. Now we'll move on to the next part. Ajay. Yeah. Hi. Ajay, would you like to say a few words, Ajay?
I mean, thank you so much, to yourself, the entire team. Chitra, you have been simply superb, constantly following up on behalf of the society to make sure that the program indeed took place. And, and I can see there is an attendance of 84 people right now. And it's an absolute delight and pleasure to be here on behalf of Shanta Kumari and Foxy and the entire team at Foxy and WHO, in whose partnership this whole program is being done over here. And good to see you, Suma and Bhanumati, as well.
Thank you.
Both are faculty and taking this process forward in the right earnest. One of the biggest thing that I miss of Coimbatore is your what is that Sri Krishna sweets? I remember it right.
Yeah.
You can come to Coimbatore, we will give you.
Yes. I always miss that. I haven't been to Coimbatore for the last decade or so now. It's time that we come there very soon once things open up. Just to also let you all know, on behalf of the program, WHO and Foxy, we have conducted about 15 RAC programs so far, of which 3 of them have been national, rest all of them have been in the society programs. And congratulations to Coimbatore Society, because you're the first one in your state to have initiated and given this program. So a huge congratulations to each one of you. I saw there were 167 registrations. However, 84 have joined. I'm sure they must have been busy or pulled into something or the other. You please feel free to organize few more such sessions for the society, and we will allocate all the Zoom, and this must have been a very smooth experience for you getting all this going. We will once again arrange a couple of Zoom calls for you all, and you can go ahead and plan more workshops. And with those more workshops, I would also strongly recommend, if you have some neighboring societies whom you would want them to join, feel free to do that. So it's not limited to any one society. Coimbatore Society and you all can be the leads for that program and spread the message across other societies in the neighboring states or neighboring districts. And they are also free to join and initiate this entire thing. So I can see Suvarna is writing Salem Society is also interested. Please go ahead. Send us an email, and in the email indicate the date that you wanted, the time that you wanted, and expected number of people. Based on that, we will send you a reply back with allocation of the Zoom on that day or any other. So give us 2 alternate days and 2 alternate times, because there are back-to-back programs which are happening and which will go in the case of Coimbatore Society also. Give us 2 or 3 dates going forward and timings, and we will allocate the Zoom accordingly, and that will do it for Salem or any other society who would like to do this in their this thing. And please feel free to add any more societies that you would like to do. Send the information. If they want to join, great. If they don't want to join anyway, you are anyway going to carry on with your program. So that's really wonderful. And if there are any operational questions, I could be happy to answer them. At the end of the session, we are seeing after every presentation, there is something known as registration, pre-test, post-test, and feedback, which is all compulsory. Registration and pre-test is the reason why you're here. And post-test and feedback, either Chitra or Sum chat box, okay, the link. So you just have to click the link in the chat box. You will be taken to a screen where you can submit your post-test and feedback. Basis all these documentation and your attendance, the backend will be processing the certificate, and in a week's time, hopefully they should be releasing all the certificates to members who have joined and completed this entire process. In case you miss out on the chat box and do not find the link, do not worry. When you exit the meeting at the end of the meeting, you will again get another pop-up to submit the same. And even if you missed that one, all who have attended and not completed the 2 feedback and post-test, the backend will be sending you all one-on-one emails to give you one more opportunity to submit all of that. I can see Bhanumati is smiling because she has heard this innumerable times that I have been speaking about this in every forum that we are talking about. So
Ajay, there's one clarification. Ajay, can I just ask you, Ajay? In a chat box I've written, how can we access these modules for a future use?
Yeah, for future use, once the program, it's a FOGSI WHO program done in partnership with the society. So the society is the lead. So once the society completes the program for majority of the members, the society would be then advised to share the PowerPoints with the other society members, should you wish to carry on a program thereafter. But there
we can bring in a book, no?
Sorry?
We can bring in a book on these modules.
Yeah, that's the
like
whole
the
plan.
focus, Foxy focus books.
Yeah, that's a whole plan, because out of these 15 sessions that we have had tons of questions in the chat box also, and the replies to them. So it will become kind of a module by module book, followed by a Q&A section. So there'll be Q&A related to the forms, Q&A related to the medical board advice, Q&A related, so we'll try to work it out and how those sections can come out. So the discussion with WHO is going on, how to make that actually possible. So, so absolutely, it will be a delight to have each one of you take the program forward, but let the society finish this on behalf of FOXI and WHO, and then you can do it. And there again, if you want to do it using the FOXI and WHO logo, then you will have to inform us, so that then we can allocate the Zoom for you, and then you can do it in small clusters for yourself. Few clusters you can put together and take it. And if you want these slides for your reference, by all means, they will be shared with you at appointed time. There is also a video recording of all the sessions that have been conducted, including yours today. So this link will also be shared with you in due course of time once this whole process is complete. So you can always go back to the YouTube video and look at the section that you want to and help yourself with that. I see Nazia Ansari. Nazia, you have a question on admin, or it's for Chitra and the team?
No, I don't see any question.
I can see her hand is raised.
Yeah.
So if it's my mistake, it's okay. So carry on. All the very best to each one of you. I'll be there for a little while. From here, I'll be hopping back to my other program, which is going on Dhira, and I'll possibly come back here again if required. And Chitra, you can always message me and I can come back here.
Okay, fine. Okay. Thank you so much, Ajay. Thanks a lot.
Of you. Before I leave, I'll post the post-test and feedback for each one, 3 of you individually, so you can use it at the end of the session, at the end of the program. Okay.
Okay.
Yeah.
Okay. Okay. Thank you, Ajay.
Bye bye.
Okay. From now on, we'll move to this saver. If there are any postgraduates, please note what exactly is the saver, because you might be getting a question, saver short notes. So what is the saver? Saver is safe abortion values, evidence, rights.
The screen is not on.
Madam, screen is not on.
We're not able to see the slides.
No, ma'am.
No.
No.
No, we are only seeing you.
Oh, oh, sorry. Wait. No, ma'am.
Yeah.
Seen. Okay. So, like I said, what is a saver? Saver is nothing but safe abortion values, evidence, rights, and respects. In fact, like I told you earlier, after having listened to this, my thoughts about abortion also changed. And I realized that sometimes I have made a mistake of refusing an abortion to a person. But I think that was not the right way in which we should have done it. And this really, was an eye-opener to me. So this module tells us what is the definition, what is RAC, respectful abortion care, and highlights what is the norms and stigma which affects our services. There are 2 short videos which tell you about that, and provide a WHO saver resources for RAC. Now so I'm sure all of us would have learned all these things. The law has changed. We can go up to abortions up to 24 weeks of pregnancy. And FOXY being a very large society, we have more than 36,000 members. So it's the largest provider base for abortion care. In fact, globally, ours is the first person to take up this RAC and to percolate it amongst all our members. That's a drive that we have. So online courses were possible because of COVID. Many people, we know that they could do telemedication and get the required medications. So because that was an eye opener, and many people started doing this online. You should not confuse this MMA with the PCP NND. Both are totally different. Also, POXO is also different. Now, what is meant by RAC? According to WHO, it refers to the care that maintains safety, dignity, confidentiality to the. So we should not disclose who's having the abortion. You must see that she's safe. You must look at her in a dignified way. And like Hippocrates, you see that no harm is being done. So ensures freedom from harm and mistreatment, and enables informed choice. You must tell about all the choices that she has for the abortion. And lastly, continuous support during and after all types of abortion. So you must see that you give her a lot of dignity. You look at her, we treat her with respect. So now there's all these respectful maternity care, respectful abortion care. Basically, means that you have to treat a person with dignity and respect. That is what is most important. She's come to us as providers. It's our responsibility to see that everything goes on well. You treat her in a respectful way, and you see that she's free for any harm, and you give her all the choices. Whatever the patient opts for, is our duty to provide her with that choice. But it's important that you tell her all the plus points and the negative points. And throughout the procedure, whatever she opts, it's our job to support her throughout this procedure. Now, in simple terms, you should treat the patient with dignity, empathy, and compassion, regardless of who she is. She could come, whatever her ethnicity is, whatever be her background, whatever be her socioeconomic status or reproductive history. We have to treat everybody with the same dignity, empathy, and compassion. If you think that you've done something wrong, then as a health professional, it is our duty to listen and support. And communication is the key to success. So what are the norms and stigma? We'll come to that. Okay. Now, these are certain things which we come across or which we might have heard or seen in our own places. Physical abuse, slapping the patient, it is not right. Verbal abuse, shouting at her and screaming at her, again, is not to be done. We see, who asked you to come for this abortion? We never told him. So all those words should not be spoken to her. Sexual abuse. Or can you, Kumar, mute everybody, Kumar. Thank you. So again, you should not sexually abuse a person, especially when she's under anesthesia, etc. You should take utmost advantage. Don't take advantage of the patient when she's at your mercy. And you must see all these videos. What is the difference between stigma and discrimination? And always you must maintain good standards. That's why this program about how to maintain uniform care throughout. There should be a standard of care, and you should have a good rapport between the patient and the provider. So what are the 12 domains of this respectful abortion care? Many of these might be repetitions, but just to say, bring no harm to the patient. Maintain privacy. Like Dr. Bhanumati said, you should not disclose to anybody unless it is by law who is having the abortion. You should not be told to anybody. And you must preserve the woman's dignity. You must respect her choices. She might want something. She might, if it's 12 weeks, she might want only a vacuum aspiration. She might not want a medical abortion. So you can't force, this is better, you do this. So whatever she wants, you have to give her the choice. And like I said, soft skills in communication are very, very important. It should be very empathetic to the patient. You must give her all the information about all the different methods. And throughout the procedure, continue to give her support. And whatever you do, wherever you do, you must see that the physical environment is, the quality is good. You have, it's done in a very clean place. So all the surroundings should be very important. And equitable abortion care. For everybody, the same method should be done. And it should be done by competent and motivated providers, not by anybody. So once you have this course, you will all be certified to conduct these abortions. And like again and again that we're emphasizing, it should see why we get angry with the patient is because she might be repeatedly coming for abortions. So that might be the time, so that might really irritate you. But on the other hand, that is a time when you really have to tell them to have some contraception. So you have to really emphasize abortion, contraception, because she'll be easily willing to accept. So the more you emphasize, the more willing she will be able to take up that contraceptive advice. And again, counseling and continuity of the care, because after follow-up she can have some complications. So that is why a few days ago, maybe a few months ago, we had in a WhatsApp group, I'm sure all of us will know, restrict the number of abortions that we were doing, because Well, there are a lot of not restrict. Basically, they said many complications are happening because of abortions. So don't do abortions unnecessarily. So on the other hand, here we are saying do abortions. So the idea is you must do abortions in a center which is certified, and when you're going to do it in a correct manner, so that you avoid the complication, because the person has the right to ask for an abortion. As providers, we should be able to give them the right way. Instead of just not doing abortion doesn't mean we're fulfilling it. See, if you don't do the abortion, it's going to go elsewhere and have the abortion. So it's better that you do it under supervision in a good way. That should be the answer, rather than saying I will not do an abortion because all these complications will come. That should not be the answer. Do the abortion, do it in a proper way. So again, if it's less than 20 weeks, it's only one provider. If it's 24 weeks, if it's less than you have to have a special person. If it's more than 21 weeks, and then if it is beyond 24 weeks also, especially if it's a case of some gross anomalies, there is no upper limit at all. You can go up to any weeks of pregnancy. Okay. Okay, these are various websites that you can go through for the saver. There are some questions. I'm sure you've seen these questions. According to WHO, restricted access reduces the number of abortions. Is it true or false? The answer is false. So if you do abortions by the right trained persons, by appropriate methods, it is safe. And again, MTP Act, a woman, a minor less than 18 years, should she get a written consent? Again, false. Okay. A 30-year-old recently widowed woman wants to have an abortion in 22 weeks. As a provider, it is your responsibility to tell her to continue the pregnancy. It's 22 weeks. So would you tell her to continue the pregnancy or not? No, because she has the right to decide whether she wants to continue the pregnancy or not. You cannot tell her, for 22 weeks, go ahead and continue the pregnancy. She has the right, because we can't do abortions till the 24th week of pregnancy. Okay. So now let me just stop sharing and show you 2 videos. Amla, Amla ma'am, are you sharing your screen, ma'am? One minute. Amla madam?
She actually logged in, she did join, but yeah, I saw her doing.
Okay. Enga in the slide. Ena inga Amla Bhanumathin varudhu unga sleep. PowerPoint.
And the videos, what happened to videos?
I'm searching on.
Somebody has to open that. உங்களுக்கு கொடுத்திருக்காங்கல அதுக்கு link, videos link
கொடுத்திருக்காங்க.
இல்ல post abortion contraception.
நீங்க போட்டீங்களா? நீங்க போஸ்ட் பண்ணீங்களா பானு? உங்களுக்கு இருக்கா?
இல்ல உங்களுக்கு
1 minute. Kavi. Kavi, இந்த வீடியோ எங்க கவி? வீடியோ எங்க பாரு, நீ எங்க என்ன மூலையும் ஓபன் பண்ணாம வச்சிருக்க? வீடியோ எங்க இருக்கு காணோம், வீடியோ காணோம். எங்க போச்சு? டெஸ்க்டாப் போய்டுமா? எங்க காணோம்? இதெல்லாம் மூணு ஓபன் இதுயா? இது எதுக்கு இது மூணு?
No woman should die due to an unsafe abortion. And when abortion is provided,
Okay,
it should be given in a legal and evidence-based manner. Safe.
Can you see the video?
No, ma'am.
No.
No woman should
Wait,
Ma'am, just open the
Huh?
video. Open the video. Stop playing the video. After that, click on share screen button, ma'am. And below there will be two options, ma'am.
Is it the desktop? 1 minute, ma'am. இங்க இல்ல அங்க வச்சுக்கோ அதுல காணும் நீ அதுக்கு டெஸ்க்டாப் இருக்குது just bear with me for a few minutes. நீ அங்க நீங்க போற வரைக்கும் இது மினிமைஸ் பண்ணு எங்க நீ டெஸ்க்டாப் போறல
no woman should die due to an unsafe abortion and when abortion.
Yeah, something we are hearing, Chitra.
இல்ல பண்ணு are you not seeing பண்ணு
இல்ல very well.
desktop
Nearing 4, are they extending?
இல்ல மேடம் நீங்க பண்ணிட்டு நான் நெக்ஸ்ட் வீடியோ
She can finish. Suma can
மேடம்
finish.
நீங்க finish மேடம்
Okay then.
நாங்க
Yes,
because
sir.
this video
By the time you get ready with the video.
Shall I start sharing?
yes ma'am நிறுத்து நீங்க மேடம் you start sharing இது எடுத்து உங்களுக்கு போடு சொன்னாங்க எங்க நீ வச்சிருக்கீங்க இந்த கிரில்ல நீங்க பார்த்தீங்க
Are you seeing that?
Yes, ma'am.
Yeah, I've seen.
yes ma'am எங்க நீ டெஸ்க்டாப் வச்சிருக்கீங்க பார்த்தீங்க இல்ல
Hello, Ravina. கொஞ்சம் திரும்பி கொஞ்சம் help.
I think we can mute the others, isn't it?
yes ma'am please
Yeah, coming to the last but one topic of today's session. This is on pre and post-abortion family planning counseling. I bring greetings from Ganga Women and Child Center and Craft Fertility Center. Now, we should know what is counseling. Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts and feeling and perceptions. Now, every woman who seeks comprehensive abortion care definitely needs counseling. Now, this counseling can be done by the midwives, they can be done by the paramedical staff, they can be done by the doctors or whoever is trained in with regard to counseling of comprehensive abortion services can do it. So it's very important that the counseling has become an important part of the integral part of the comprehensive abortion services. And remember that this is as important as the procedure that we are performing. So women may need to help in decision making as to what kind of methods that they need to use, either the medical method or the surgical method, or whether they need to have the abortion at all. They need our help to make a decision. So wherever needed, see that the spouse is also counseled regarding this. So what is the critical role of pre-procedure counseling? One is you help the woman to decide about the termination of pregnancy. At some particular period of pregnancy, you will have certain methods. So you need to tell them what kind of methods could be used at that particular time when she comes to us with the pregnancy. And it also helps the woman to choose the method of termination and ensure the delivery of complete information about the procedure. And it also helps women to adopt a contraceptive method. This is the time they are more vulnerable for a contraceptive advice. Then it ensures you have to definitely, as Dr. Banu and Dr. Chitra have emphasized, you have to ensure privacy and confidentiality. You can't be just speaking to her or in front of a lot of people around her. be non-judgmental and be sensitive to her needs. Establish a good rapport. When you establish a good rapport, because abortion is something that people do not want to really discuss a lot. And if she has had a termination of pregnancy somewhere else, she may not be telling you regarding this. So if you establish a good rapport with her, she will be telling you about all these things, and then probably you can avoid certain kinds of infection when you're doing a repeat termination in that particular patient. Use simple language and allow the woman to clarify her doubts. If she has made up her mind for termination of her pregnancy, then assess her for the procedure that she needs. Now, the relevance of peri-abortion family planning counseling is that there's a quick return of fertility, opportunity time for contraceptive acceptance, then allow 6 months gap between this pregnancy and the next, and health benefits and better future pregnancy outcomes. Now, 90% of the abortions related maternal mortality can be prevented by ensuring contraception. Now, when do we start doing the family planning counseling? Now, especially when you start even with the first visit. Now, when she comes to us for termination of pregnancy, probably this is the time when you can talk to her about the different methods and also about the contraception. Except in conditions in grief management, you can slowly delay the counseling of contraception. Now, what do we counsel? One is return of fertility within 10 days or 4 weeks of the method, help with the choices and the method of specific counseling in certain conditions, and the high-risk behavior wherever applicable. If the woman is not willing for any contraceptive method, please do not refuse medical termination of pregnancy. Try and counsel her after the procedure. She may be more vulnerable at that period of time. If she's still not willing, call her for a follow-up in a week's time and again counsel her regarding the contraception. So assessing the suitability for post-abortion care is when the abortion process is complete, you're sure that the abortion process is complete, there is no existing infection, no injury to the genital organs, and the chances of fresh pregnancy is ruled out. So when you rule out all these 4 particular points, you could give her a contraception. Now, the post-procedure counseling, the critical role is that it ensures the woman has understood the precautions and care that are needed during the post-abortion period, and opportunity to counsel for contraception in case they are not previously accepted. And it also reinforces the need for continuing the use of contraceptive method which they have already chosen for. So, post-abortion counseling, the procedure includes continue, reassure, and repeat. Continue to ensure privacy and confidentiality. Reassure her in any case of any problems that she goes through, either with the method or with the decision making, and repeat the information about the post-procedure care and the danger signs like abdominal pain, fever, heavy bleeding. She can come to us and immediately see us. Now, the counseling, if they have already adopted any kind of contraception, you must appreciate them. Now, you must appreciate them for following the contraception. Immediate care of IUCD, intrauterine contraceptive device, or injectable injections, the ongoing oral contraceptive pills, and then counsel them regarding the follow-up protocol, the continuity of these contraceptive methods, and give them cards, especially when you are using an IUCD for 5 years or 10 years, give them cards so that they can bring back the card when it is expiring. Now, if they are still undecided about the contraception, allay the anxiety and importance of immediate adoption of the methods chosen and the extended period of adoptions, couple counseling need to be done, and you can also talk to them about emergency contraceptive pill. Now, coming to the different methods, when can we use these methods after an abortion? Now, for example, take barrier methods. Barrier methods can be used as soon as the sexual activity is resumed, especially in the first trimester, as well as in the second trimester. And the importance is that there is no hormonal side effects. It can be used without any consultation of the health provider. It is easily available, and prevention against STDs, including the HIV, and it enables the men to take responsibility of contraception. Now, the intrauterine contraceptive device. When can we use a device after an abortion? Now, in the first trimester, you can insert immediately or up to 12 days after the confirmation of a complete abortion using the surgical method, or if you're using a medical termination, inserted around 15th day of the process, provided complete products of conception expulsion is confirmed and the risk or presence of infection or any other contraindication is ruled out. Now, in the second trimester, intrauterine contraceptive device can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. So the advantage is that it's highly effective, provides long-term contraception for almost 5 years to 10 years, depending upon the type of IUCD that is used. It can be provided by the trained doctors, ANMs, nurses for the first trimester, and MMA also can be used. The postpartum IUCDs can be used by the trained doctors, and no interference with sex, immediate return to fertility on removal, and no hormonal side effects. And when you come to combined oral contraceptive pill, in the first trimester, you can start COCs immediately or up to 7 days after abortion using a surgical method. And if you're using a medical abortion, it can be started on day 3 with the dose of misoprostol or with the day 15 of the process after confirmation of complete abortion. Now, in the second trimester, immediately or up to 7 days after abortion. Now, the importance is that it regulates the menstrual cycles. It can be provided by all health workers after first screening by trained provider, no interference with the sex, offers protection against ectopic pregnancy, endometrial or ovarian cancers, and benign diseases such as fibrocystic or fibroadenomatosis. Not suitable for women who are breastfeeding babies less than 6 months old. Now, coming to the long-term injectables like medroxyprogesterone acetate, in the first trimester, you could start this immediately or up to 7 days after abortion using a surgical method. But with the medical abortion, it can be started on day 3 with the dose of misoprostol. In the second trimester, after second trimester abortion, you can start immediately or up to 7 days after abortion. Now, the advantage is that it's highly effective, confidentiality and privacy is maintained. It can be provided by the doctors, Ayush, ANMs, nurses after screening by the doctors for the first injection. There's no interference with the sex, no effect on the quality and quantity of the breast milk, no estrogenic side effects, offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Now, coming to the permanent methods like female and male sterilizations, female sterilization can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days. Both minilap and laparoscopic sterilization can be done following a vacuum aspiration. With the medical abortion, it can be done only after the first menstrual cycle. Now, in the second trimester abortion, a minilap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended. But we have been doing it. I don't know why it's not recommended. The advantage is that permanent method of contraception, highly effective immediately, no interference with sex, no effect on breastfeeding, no long-term side effects. It offers protection against ovarian cancers. Of course, vasectomy is performed on males, independent of the timing and procedure of the abortions. Now, this is with regard to the contraception, when it can be used as a summary. Now, the combined oral contraceptive pills, this is with the medical abortion. Injectables and centrochrome can be used on day 3 or on day 15. IUCD definitely on day 15. Now, similarly with the vacuum aspiration, it can be used immediately within the 3rd or 4th or 5th ray. And IUCDs can also be used as early as possible. Tubal ligation can also be done in the 3rd or 4th or 5th ray. Now, coming to the sexual reproductive health services. Now, the latest is that it may help address the unmet needs of the reproductive health needs, particularly rural population and transportation and childcare barriers. Now, a wide range of reproductive healthcare services are provided via telemedicine, including the combined oral contraceptive pill, the MMA, and the STD infections. These services However, though they are very popular, they are still not being used regularly by the patients. It's just used as an adjunct for the services that is performed, and its use still is very low. So, but then you can do the teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. Now, there are certain websites which are called as Hamdo. Social medias like Ask Tanu and YouTube's are regarding, even it's available in the YouTube. Infographics are also available, like a lot of pamphlets, and then a lot of patient education platforms are available, like WHO and RCOH, and helplines are also available. Now, what is the SWOT of these telecommunications? Now, the strength is that you all remember that in the COVID era, we definitely had a lot of telecommunication consultations and treatment, approachable throughout the process with confidence and awareness, spread out questions and answered at ease. But then the weakness is that there is no face-to-face and demonstration is not possible. The opportunity is the privacy and comfort is maintained, it is cost saving, and the number of visits are cut down. The threat is it may be a missed opportunity and a misdiagnosis. Applicability of these comprehensive abortion care is the assessment, confirm the diagnosis and the contraceptive need, counseling with the video conferencing or Zoom link. Follow-up you can do with the hybrid services or for online, and it may be 1 visit or 3 visits depending upon the type of method that you use. Now, so the key message is realize the need of post-abortion family planning, bring the couple on the board and strive for 100% coverage, capitalize the basket and applicability in the post-abortion period. Technology can be used as much as possible. Scope for entry into comprehensive abortion services. But the concern is that the policy may be different in different institutions. There may be a malpractice with regard to this. Service costs may be a little high, and access may not be possible in certain cases. And adolescent reproductive health needs definitely need to be both online and offline. Thank you.
Thank you, ma'am, for the very wonderful presentation. Now we'll just move on to the slide, video. Any questions, please put in the chat box. Madam, we'll stop sharing, ma'am.
Yeah, I'm just doing that. It's not coming, stop sharing. Not able to stop share.
That sharing and stop sharing only, it's taking a lot of time, I think.
No, I'm not getting that on the. Where is that stop share?
The video is like நீங்களே போட்டு
எங்க இருக்கு வீடியோ?
இல்ல இருக்குதா?
எனக்கு இந்த ஸ்டாப்பே வர மாட்டேங்குது, எங்க இருக்குன்னு தெரியலையே.
Stop. Madam, put this, close this உங்க இது மேடம். Close it மேல அந்த into button close பண்ண போகாதா? Just close that button on top, ma'am. Okay. Now I'll share. Video. Some of this video is not playing for me. Can the the Kumar, can you help me? I'm not able to share at all.
Yes, ma'am.
Can
Please
you just
open
play
the
the two
video.
videos? I'm not able to share at all. The two videos, module 3, can you just share the two videos? Because I do not know, for some reason I'm not able to share.
One second.
Yeah. There's a question. When a 16-year-old comes for an abortion, no need for parental consent before doing MMA or vacuum aspiration, but should be informed under POXO.
Yes, they should be informed and police intimation and the consent from the guardian, including examination, that has to be there.
See, POXO is different and this is different. You have to, under POXO, you have to inform. But here, abortion you cannot deny. Both are slightly different.
Maybe in the private hospitals, you can refer them to the government hospital for the further management.
Kumar, are you sharing, Kumar? Kumar? Any other questions for a minor? From whom can we get consent? Banu?
Guardian.
From
The guardian.
No, what happens if there is a complication following abortion? She comes alone for the abortion, and then there's nobody along with her, and then there is a complication arising. So who takes the responsibility, and how do we manage this?
No, there should be a responsible adult accompanying the person to undergo abortion. There should be, because the confidentiality when it comes and all, no, all the details are given only to that person who is an adult responsible person.
We had an experience. There was a boyfriend who came along with her, and then the moment we said there was a complication, he just ran away. And how do we manage such kind of patients?
No, it's a practical problem, I agree. But that person, nowadays, it's not an uncommon thing to see. A lot of times they only come. If you're little in our scenario or society, if you're able to catch hold of that person, that is good. Otherwise, you need to ask that girl to bring her family members.
No, she is sick and she has complication. Where will she go?
No. When you are doing the procedure, that boy has to be there. If he's not accompanying, he will not be able to, he will not stay back, they won't do like that, we have to say. Any person getting inside the hospital, we request them to have one person responsible stay back. That has to be done. It should be followed. I think we need not apply unless somebody is responsible. It's clearly mentioned as like that. As per law also, somebody has to be, unless otherwise we don't do anything. Even for doing HSG, some people develop some reactions. I think it's better accompanied by somebody.
Kumar,
Chitra,
are you getting it?
Ma'am, we don't have the videos.
You don't, Banu, உங்ககிட்ட இருந்தா கொஞ்சம் share பண்றீங்களா, Banu?
Ma'am, if you have
Can I just log out and then log in?
I'll try from that. I have no open. Wait a minute.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity. These may be rooted in stigmatizing attitudes or contribute to
Can we,
from a personal perspective.
Kumar, can I share my slides, Kumar?
Knowledge or interest in
Got
Kumar?
it?
further use of WHO guidelines
Kumar?
and tools with a focus on guidelines.
Please, sir, enable me to share screen. I'll try again.
Towards the very steps
இல்ல வா
Okay.
நம்ம என்ன விஷயம்
Huh?
பாதி சாப்பிட்டு இருந்தேன்னா
Kumar?
building resilient health systems for universal health coverage for
இங்க
UNC.
என்னோடது மியூட்
Yes, ma'am.
இல்லாம
I have enabled. I have enabled.
Quality and dignity of care matter as much as saving lives. SIGPA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, respect.
பாதி முடிக்கல சாப்பாடு பரவாயில்ல
Ma, I really can't share my.
இது என்ன
Ma'am,
இது?
while sharing after
No,
clicking the screen
Kumar,
button,
see,
You will get
it's not coming.
ma'am, after clicking share screen button, there will be two options.
Okay, now is
below.
it coming?
you have two icons. One icon will say continue and one icon will say exit.
Ma'am, please stop the video once.
I'm
Stop.
able to hear. Can you hear?
No, ma'am.
Now?
No,
No.
no, ma'am.
இதுல வீடியோ ஃபோல்டர்னு இருக்கு பாத்தியா
After
Video
clicking
saver.
share screen button, there will be two options below.
No, there's nothing. It's not coming only in my screen.
இது இல்லையா இது என்ன இது இருக்கு
Now it is coming,
இது
ma'am.
எங்கிட்ட இருக்கு பாரு
Okay, this now?
The audio is not coming, ma'am.
Now,
social norms are the unwritten rules.
Yes.
என்னோட இது Zoom இங்க இருக்கு. இதான Zoom. Yeah, you got the video. You got the video?
Banu, I'm not able to see it. Banu, it's not coming on my desktop. I'm able to play, but
shall I share? Chitra, shall I share?
Please, no, please share. Somebody share. No, only for 5 minutes.
No, you stop sharing. You can speak. Wait.
You just share, Banu.
என்கிட்ட ஒன்னு இருக்கு பார்க்கலாம் அது வருதா?
Okay, sure.
எங்க பண்ணது?
Because inga Thanyavar I'm not able to share because we're just holding back everybody. Kumar, you don't have those, sir? Shall I send?
Accepted. Okay.
No, because in the background I can hear my video, but I'm not able to see.
Illa. Let me share screen. 1 minute. Share. Okay. Am I audible? I mean, the sharing.
Yes, ma'am.
Yeah, sure. You can proceed. 1 minute.
Yes,
1 minute. I will. It's a video.
Okay. So this is a video about what are the norms and stigma.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptive than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. it is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
Banu, stop sharing, Banu. I will try mine. One more video is there.
பண்ணுங்க.
I will see, Banu, whether it's
Sure.
because அதுவும் வரதான் தெரியல.
இல்ல நான் பார்த்து வைக்கிறேன் அடுத்தது.
Okay. Stop பண்ணிட்டீங்களா, Banu?
பண்ணியாச்சு.
Okay. It's not coming onto my desktop at all. Na video Kumar.
Yes, ma'am.
Kumar, I have opened it on my desktop, but it's not. I'm not able to share only. I can see the video on my desktop, but I'm not able to share it. What's the problem?
Once open the video and play it, ma'am.
Open the video and it's opened only. It's playing.
Okay, just pause the video.
No woman should die due to an unsafe abortion.
Pause the video, ma'am. Pause the video.
Pause the video.
Then go to Zoom. Come to Zoom.
And when abortion is provided, it's abortion.
No. Stop the video, ma'am. Come to Zoom.
1 minute. Okay, now pause the video.
Then share screen. Once share screen.
Okay, where is Zoom meeting?
Share screen button is there, no, ma'am?
Yeah.
Open. Just click on that.
Okay, share screen button and then click on it.
Can you see the video?
No, I can't see the video on the desktop.
Okay.
Chitra, I can show you this.
Okay, Banu, because okay, we'll show. Okay, Banu, I'll stop sharing.
நான் ஷேர் பண்றேன்.
Okay, sorry, Banu.
இல்ல, it's okay. He is allowing me to share.
Okay, please allow Dr. Banu to share, no?
Okay.
My screen is seen?
Yeah, Banu. Yeah, please go ahead, Banu. Thank you, Banu.
இருக்கட்டும். அது வீடியோ தானே. Yeah.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SAVA toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVA has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in,
and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Thank you, Banu.
One
So
more video.
Only two, Banu.
Okay.
Only two videos. You've shown both. So that brings us to the very end of this meeting. End. The form fit that brings us to the very end of the meeting. Kumar, can you just give them the link so that they could?
No, I will give that.
Forms.
I will put it in the chat box.
And so, so what we've seen today was you had the newer developments about the MTP Act, what the amendments and how it is changed. And all of us should remember that the abortion, you have to treat everybody with respect and compassion. That's the most important thing that we have to take home. And you must know what are the pre-abortion counseling, the abortion procedure per se, and what is the post-abortion family planning advice that you have to give. And Banu, would you like to just conclude and thank all the participants who have really logged in for such a long time? And I'm extremely sorry if I do not know for some reason the video is not was not working. And thanks, Banu, for having questions.
No problem. Whether you're able to see the link, is it in
the link is earlier, Banu.
No, I copied and pasted there. And
the link is there in the chat box.
Yeah, I have now. 1 second. Okay, it is there at enter.
So you all can.
I will show you that also. Actually, this is a good program and extremely important to streamline and have a uniform practice. And definitely the abortion related complications will be reduced by that. That is why it has to be mentioned. And I think it's a very step by step it has been mentioned regarding all aspects and how a woman has to be treated, how her other things has to be dealt with. All these things are given. I think we need to play much more fine-tuned and give a proper healthcare. As we are doing it, we are going to streamline it again. And I think everybody will follow that. I'll try to post that again. The link. No. I got the copy and then.
The link was there, Labano.
Whether it is can't see that can't see or here. Somebody has written. No, I will. It's in my this thing. I will do that.
It's not.
Kumar is there.
Kumar,
everyone.
That link was there earlier. Did you copy the link?
I copy பண்ணிட்டேன் நானே paste பண்ணிட்டேன். அது send பண்ண மட்டும் வர மாட்டேங்குதே. Can chat with everyone. இங்க வா ஒரு நிமிஷம். I copied the link. Actually, it is in my chat. This thing. I have to post it. That's all. இத அனுப்பு send பண்ணு. Just send this. This is the link.
வந்துச்சா?
என்கிட்ட இருக்கு, இங்க இருக்கு.
Just please post the link. Sorry.
No. I will
share the link. No link for them to do the post test.
உனக்கு கரெக்ட்டான லிங்க் நான் காட்டுறேன்.
It is gone. Can you just share it again?
This is the link. Share பண்ணி.
Okay.
We are sharing, man. We are sharing.
Okay. Thank you. Man, I've told Ajay he will come.
In a minute, it is coming.
Okay.
What is the feedback from the people? Somebody was asking about the medical board. We have that in the our race course. The link has been sent, ma'am.
The link has been sent.
Please follow Dr. Ajay's instructions, and you need to reply with the post test as well as continue, and then you go ahead with the feedback so that you will be given a certificate. That will be the completion rather than quitting after the post test. You should not be.
You just take 5 minutes. You can just finish off the question now only.
Yeah. And
some 20
the certificates are expected to reach you by mail in a short period. That's why this is required. Unless you complete this process, it is not complete.
You can start now only because the meeting is over. You can start now.
Yeah. I think you got everybody's. Anybody? I mean,
yeah. See, the link has been sent by Ajay also. So this is the link. Okay.
I've just shared the link with you, Chitra.
Yeah, Ajay, we've already got it. Thank you so much, Ajay. And sorry for calling you back.
Completed the program. Thank you very much for the opportunity. We are open to further programs as well, sir. Thank you very much.
Pleasure.
Ajay, thank you so much. For some,
always a delight and pleasure. Always a delight and pleasure. Yeah. So if there are no other questions, then I could possibly leave.
Yeah. Please. Thank you.
Thank you, sir.
Thank you. Bye. Thank you. Normally leave panikkalam number.
Yeah. It is the link they have.
They can
take it up.
Okay, thank you, all of you all. Bye, Banu. Thank you so much, Banu.
See you
Thanks,
later.
all delegates. Thank you.
Okay. Bye.